Welcome to In-Depth TV. My name is Dr. Joseph Santoso. I'm so glad to have you here. And I'm very excited. We have a special guest, Dr. Susan Murrmann. Dr. Murrmann, welcome.
Thank you. Thank you very much.
Let's talk about as women get older and they go into menopause, what are they expected to have?
Well, that's a loaded question because the symptoms and what happens during this course of time when your hormones start to slow down, women can have so many different symptoms, and one woman can be different from the next woman when it comes to the symptoms. Some women don't have many symptoms at all, which is good, and it sort of tends to be familial. If your mother went through menopause in a good way, I think you have a good chance of doing the same thing.
Wonderful. Wonderful in the sense that it's kind of predictable. It's nothing too uncommon.
Well, the part right before menopause is unpredictable.
I see.
Different women experience it in different ways. We all know that your hormones start to wildly fluctuate during this time, and women can get mood swings, they can get fatigue, they can get joint pain, they can experience all sorts of things like irregular bleeding, or no bleeding, or heavy bleeding. So that's a very tumultuous time for a lot of women right before they go into menopause. Now, I can tell you 100% when they go into menopause that they're going to have hot flashes, fatigue, and joint pain. And really, it's not as crazy as before you hit menopause. So sometimes going into menopause is an easier situation to deal with than premenopause.
What are hot flashes? We heard so much about it.
And I think men have them too. They just don't want to admit them when they lose their hormones. But women can experience just profuse sweating, or like one person described, this internal wave of heat that she would get. And mainly they tend to come at nighttime, and I think that's what the fluctuation of hormones does, coming from the brain, or the lack of hormones can cause. But they can be very uncomfortable. Women, report that they're in business meetings and all of a sudden they break out into a sweat, which can be very, very uncomfortable for a lot of people, and especially women that are in the workforce and, they don't want to be sitting at their desk with a fan. And that's usually what you see.
And then the mood swing.
Mood swings, usually that's when their partners or their family tells them, go see the doctor, you're having some problems. And they get emotional. With the ups and downs of all the hormones, it can make any woman emotional, very tired, have bleeding, and then they're more tired from having this irregular bleeding. So mood swings come when you get this fluctuation of hormones. You can sort of have mood swings in menopause when your periods quit, but they tend to be more predictable and last a lot longer, or be more associated with anxiety or depression.
And how long are this tumultuous time women should suffer through? Again,
it's independent on each woman. I've seen women, one day they're having normal periods, the next day their periods stop, and that's it. It's not very frequent. That's 3% of the population. But a lot of women will maybe go through it from 5 to 10 years.
Wow.
Yeah. And that long. But you just don't know. It's all very, very independent.
All right. Some of our audience says, yes, I have it. Exactly what you says, Dr. Murrmann. What could I do about it?
See your physician, because they can actually help. There are things you can do in this perimenopause time. If you're a candidate for birth control pills, you don't smoke, and you're in good health, birth control pills can sometimes even out the hormones and give you a better quality of life. A lot of times I put my patients on a cyclic progesterone to keep their periods once a month, and progesterone's a natural antagonist of estrogen, so it helps even out the estrogen as it's fluctuating up and down, and sometimes can provide to be very calming for patients and help them, especially with the mood swings and the irregular bleeding.
Now, when I hear about hormone, some of my patients will say breast cancer or other cancer. What are the relationship between some hormone with some cancer?
Well, I think if you look at your entire body, you have estrogen, progesterone, and testosterone receptors everywhere. You even have it in the skin. It can be associated with aging. It's associated with vaginal atrophy. We know that. So there's receptors for just about every hormone everywhere in your body. So if you get a breast cancer and you're premenopausal and you have these fluctuations of hormones, of course, if you have a receptor positive cancer, it can encourage the cancer to grow. The same thing if you have a breast cancer and you're postmenopausally and you're taking estrogen and it has receptors, it can cause that cancer to grow. But the big debate is it really starting the cancer to begin with? And I think, we all remember the day with the hormonal apocalypse that came with the study that came out. I think it was in 2002.
This is the Women's Health Initiative study.
2002 Women's Health Initiative, WHI. They came out and, of course, they stopped the hormone trial because women were dying of breast cancer, which caused a big stir. I mean, I think women went into a panic. I was automatically called to a panel to address a lot of women's groups on this study, and two things happened. But the good news doesn't necessarily travel fast. Out of this study, when you go back and really look at the results, and it was around 16,000 women across the United States that were placed on this study, and they weren't really well controlled, but they had certain criteria they had to meet. And one of them is you are not symptomatic from menopause. So women, the average age of the female population that was in the study was around 63 years old, which they had not been on hormones for at least 10 years. And they had some younger women and they had some older women. So the population was not a great, I guess, one to study if they hadn't had hormones for a long time. Two, they were also using an estrogen that was an equine estrogen, which means conjugated equine estrogens from pregnant mares, horses. They were also using a progesterone that was extremely potent man-made progesterone called Provera. So those were, again, two of not the best ideal compounds. But when they went back and looked at all the results afterwards, years later, they looked at the ages and they looked what happened, they did not find that estrogen was the culprit when it came to breast cancer. In fact, there was no change in women that were taking estrogen alone, those that had hysterectomies, and that they didn't have an increase in breast cancer. There was a slight increase in breast cancer when the progesterone was added. But you have to realize that was a very potent progesterone and it was man-made, so it wasn't natural to their bodies. The second thing they saw was, yes, there were some cardiovascular events that happened, but then again, you're looking at a man-made sort of a
cardiovascular means heart attack.
Heart attacks and strokes. You're looking at a population that had not had any hormones in their body for at least 10 years. And then they were giving them hormones, almost like a bolus, when most of their receptors for the hormones had probably dried up. So they were giving them this estrogen that they would give to somebody probably 10 years younger. And so they were seeing an increase in cardiovascular events. And we all know from the studies that came out of Duke that progesterone, such as a man-made progesterone like Provera, has very negative effects on coronary arteries and actually tends them to vasoconstrict.
Which predispose you to have heart attacks.
Heart attacks, spasms, and things like that. So it was not a good progesterone for that. And then you look at the estrogen, which is another man-made estrogen. Even though it's a man-made estrogen or horse-made estrogen, estrogen has a vasodilation type effect on blood vessels. So you're kind of giving it the yin and yang with these two hormones. So estrogen in a good form, a bioidentical form, is really good for women and their hearts, I believe, because it increases their blood vessels to become more elastic. And because there are estrogen receptors in blood vessels as well.
Yeah. So kind of concluding that again, if I were a woman, age 50, or in the process of undergoing menopause, and I don't want these hot flashes, what do I take? What do you recommend to take?
Well, you have to look at the whole patient and assess what their quality of life is. And is this really affecting their quality of life? And it is, and then you discuss all the pros and cons of taking hormones. And, and I basically say, I can't guarantee you're not going to get breast cancer, but I don't think the estrogen's going to cause it, because there are hormone-negative breast cancers as well. And you want them to feel comfortable, because if they're uncomfortable taking any type of hormone, that's not a good quality of life either. So you kind of weigh where they are with that kind of thought process. So I always recommend a topical type of estrogen because I think that's safer.
Topical mean cream?
A cream or, they have cream, pellets, gels, patches.
Not the one that you take by mouth.
Right. That tends to go through the liver And some women metabolize the estrogen in a not so good way when it goes to the liver and may increase clotting factors. So I think topical and something that's natural to your body that you produced, like estradiol, estriol, those two compounds are safer than doing a man-made hormone, such as the kind you find in birth control pills.
You mentioned that word bioidentical. What's that mean?
Well, that's a very easily confused subject. Bioidentical to me just means it's a compound that your body made prior to menopause. So for you, it would be a testosterone in its purest form. For me, you do have estrogen as well, but in a very smaller amount. It would be an estrogen for me, or an estradiol. Now, you can get a pharmaceutically produced product that is bioidentical, such as estradiol. And you can also get a bioidentical hormone that is mixed up by a pharmacy, a compounding pharmacy, that you have a better way of trying to alter the doses with, because you can more personalize the doses. But, it's each woman's preference what they'd rather have. Would they rather have a patch? Would they rather have creams, gels? There's drops under your tongue, which I don't think are the best way to go, but some women prefer that.
So it is very important to speak with your physicians and discuss the risk and benefit for each option.
Right.
It's interesting that you mentioned about not smoking. What's smoking got to do with hormone?
Well, smoking is just bad in general.
That's right.
And we know smoking puts wrinkles on your face. It causes hardening of your arteries. It's not good for your lungs. It causes COPD, which is chronic obstructive pulmonary disease. You see all the commercials for that. That's the new biggest drug they have out there for COPD. But it just is not good for your body overall. And it also smoking along with the wrong hormone compounds can possibly increase, especially birth control pills, increase your chance of getting blood clots.
Blood clot means in the leg
In
or
the legs
in the lung?
or in the lungs. Well, the legs could eventually travel to the lungs.
And that could be deadly.
Could be deadly. So smoking is just not good in general.
Agree. And that's called pulmonary embolism, I think.
Yes, pulmonary.
Very
And what do
good.
they call it now on TV with the ads? PE blood clots.
Oh, that's right. That's right.
They renamed it for the public.
Very good. This has been very informative. You mentioned about the variations of women have to go through this, and then it's good to hear that there are some women that just skip completely.
They don't really skip it. They just don't become symptomatic. And those are the ones that, usually have a good attitude. They exercise, and they say, I'm fine without hormones, and they're fine. But that's unfortunately, not the majority of women that I see.
Right. So what you're saying is women undergoing menopause do not have to go through taking hormone.
They do not.
You
It's a personal choice.
personal choice. And
Personal choice and quality of life.
very good. On menopause and libido, tell us more about that. Libido means interest in sexuality.
Right, and that's a very big topic as well, and that probably is up there with some of the top complaints I get from a lot of women. And as women go through the changes and their hormones start to decrease, just the lack of estrogen itself can make a woman not feel that great about themselves. They might have vaginal dryness, and we know there are a lot of psychological factors that go on with decreased libido. But there's also a decrease in testosterone. And testosterone, women have receptors for testosterone and produce testosterone, not as much as men, but on a smaller scale. And so there's a balance of hormones between estrogen, progesterone, testosterone, even thyroid hormones that all feed into what happens during menopause. So a lot of times I will check testosterone levels in women, and I will supplement them if that's a big part of their lives. And usually it is. They still want to continue on with their relationships, despite what insurance companies want to do. Women don't stop having sex after 50 or 60. Like, they don't want to pay for their hormones or pay for them to have something to help them with their libido. Mm-hmm. So I see a lot of this, and we replace testosterone in very small doses in very different ways. And again, just like with the estrogen, I really believe that testosterone being replaced should be more of a topical or an injection or what we call little pellets, because anything that goes to the mouth, again, goes to the liver, and sometimes that just is metabolized incorrectly and can lead to complications and maybe